Testing 1 2 1 2. Test 1 2 1 2 1 2.
today. Feel free to ask questions if you have any along the way. So I have a few financial disclosures here. I'm a consultant for Gray Matter Technologies and also for Jazz Pharmaceuticals, but I won't be discussing anything related to those during this talk. So I'll start with the objectives. We're going to talk about how the clinical features of Parkinson's disease. That'll mostly include the motor symptoms of Parkinson's. Then we'll also go over the non-motor symptoms of Parkinson's, which are becoming increasingly recognized as important to the patient experience. And then also discuss different treatment options for both the motor and non-motor symptoms of Parkinson's. And we'll go through the different medications used to treat and interactions between medicines, adverse effects of medications, and medications to avoid in Parkinson's. So we'll start with Parkinson's pathology. You may all recognize this from your education days. This is the Lewy body, and that's the classic pathologic sign of Parkinson's disease. So the proposed mechanism through which Parkinson's pathology occurs is that there's excess protein called alpha-synuclein. And this is a normal protein in the body, but in Parkinson's disease, it forms aggregates that then can be neurotoxic. And there's some controversy now about whether these might actually be a protective response to the underlying Parkinson's disease, but the overarching idea is that it is pathologic. And I don't think I have a pointer, but in the top right panel, there are monomeric alpha-synuclein protein, which then form beta fibrils, which is that red sheet. And then they form fibrils, which leads to the formation of the Lewy body, which is on the far right. And that leads to the neuronal death in the substantia nigra. And in the bottom right panel, you can see a normal section of the brain through the substantia nigra on the top panel. And you see the black area that represents the neuromelanin of the dopaminergic neurons. And in the bottom section, that shows that that neuromelanin is lost in the Parkinson's brain. And next to that is a staining of dopamine neurons. And you can see in the top panel in the normal brain, there are a lot of neurons present there, but in the bottom panel, those are decreased. And again, another picture of a Lewy body to the right. And then from a clinical setting, from a live patient, there's FDG PETs MRI on the bottom, or SPECT on the bottom left. And the normal or control participant is on the left side. And that's, you can see the staining or the uptake of the tracer there, but it's decreased in the left brain in the Parkinson's patient on the right panel. So when the Lewy bodies and alpha-synuclein were identified, it led us to be able to characterize the pathology a little bit better and learn more about the progression of the disease. So a pathologist named Brock and his colleague Brock did autopsies on different stages of Parkinson's disease brains and developed a hypothesis for the progression of the disease. So it's thought to start in the enteric nervous system, and we actually can see Lewy bodies in the mesenteric plexus of the GI tract, and then progress to include the dorsal motor nucleus of the vagus, as well as the olfactory bulbs, and then later to the brainstem, which is when we start to see the motor symptoms of Parkinson's come out, and that's when the substantia nigra gets involved. And then it can spread from there to the cortex, which is when we see some of the later symptoms of Parkinson's, such as cognitive dysfunction. And the pictures along the bottom panel sort of show the involvement as it progresses over time, at least by this hypothesis. So first in the olfactory bulbs in the brainstem, and then advancing up through the substantia nigra to make the motor symptoms, and then the cognitive impairment in later stages of the cortex involvement. So what do we see with the Parkinson's? So we can talk first about the motor symptoms. And this is a sketch that was drawn by Sir William Gowers many years ago of a typical Parkinson's patient. Some things you can notice is that where he's standing sideways, you can see that he's got a shortened stride length. You can see he's got stooped posture. His arms are held flexed at his side, and that's from the Brady Kinesia and rigidity of the Parkinson's. You can see he's not got much facial expression. That's the masked facies of Parkinson's. And he's holding his hands in a certain posture that looks like he might be having a tremor. So we'll talk more about each of these features. So the cardinal motor features of Parkinson's, most important one is Brady Kinesia, or slowness of movement. Rest tremor is also very common. Then there's rigidity or stiffness, and postural instability or balance problems. And this is interesting. We just recently passed the 200th anniversary of when Parkinson himself described Parkinson's disease and called it the Shaking Palsy. And he said, involuntary tremulous motion with lessened muscular power in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured, although we know now that there are injuries to the cognition. So that from a walking to running pace is festinating gait, and we'll talk a little bit about that in a minute. So the first cardinal motor symptom, again, the most classic one is bradykinesia, or slowness of movement, and this is called akinesia when there's complete absence of movement. And this, like I said, is the most characteristic feature. It leads to both problems initiating movement and executing movements. So it can worsen over the disease course, and it leads to troubles completing activities of daily living because it takes longer to accomplish tasks, and even eating a meal or taking showers or getting dressed can take a lot longer. And it leads to slower movements and slower reaction times, so it can be a safety problem as well. So the way that bradykinesia is manifest is there's loss of spontaneous movement. So if you are interacting with a Parkinson's patient, you might notice that they don't speak with their hands a lot. There's not much spontaneous movement. They have decreased eye blink frequency, so they seem to almost stare sometimes. There's also a decreased frequency of swallowing, which can actually lead to drooling in some patients. Bradykinesia also comes out as a reduced arm swing, and this is often one of the early signs of Parkinson's that's recognized by a spouse, noticing a change in the way the person walks. There's also, as I mentioned in that picture at the beginning, a shuffling gait or a shortened stride length, and this can lead to tripping. There's difficulty getting up out of a chair. The proximal muscles tend to get a little bit weaker. The speech becomes more quiet over time, and it can become almost hoarse sounding. And then also the masked face that we talked about, so there's not a lot of facial expression. The bradykinesia leads to trouble with fine motor tasks, so there's trouble with buttoning buttons and other things that require some dexterity. And then there's a very classic Parkinson's disease type handwriting, which is shown on the picture here. You can see that it gets smaller as it goes across the page, and the handwriting in general tends to get smaller in Parkinson's. So it's kind of a classic feature. We ask people to write us something in the clinic to see what their handwriting looks like. And then dysdiadochokinesia is the impaired rapid alternating movements. So there's some disruptions in that movement as well. So the next, a very common motor feature in Parkinson's is the tremor. This is at rest, and the typical frequency is 4 to 6 hertz, so it's a very classic appearing tremor. It usually is worse on one side than the other, and actually can, at the beginning, be just unilateral. It's most prominent in the distal part of the limb, so you see it most in the hand and wrist, not really in the shoulder and elbow. And it is, you've all probably heard the pill rolling tremor idea, so the movement of the hand like that, but there's also a very common supination, pronation type of appearance of the tremor. And as the disease progresses, it often spreads to the other side of the body, and usually, ultimately, will involve both sides, the right and left, or the left and right, depending on where it started. And then very classic for Parkinson's, if you see someone who has a chin tremor, that is very often pathognomonic for Parkinson's disease. You don't see that in many other cases. You can also have tremor of the legs and the arms more proximally, and then the lips and jaw as well. However, you don't usually get tremulousness of the voice or of the neck. So that's seen more in essential tremor or in dystonia, where you get the head shake, the no-no, or the yes-yes tremor. Those are not very common in Parkinson's. So it's an easy way to distinguish between those disorders. But like I said, tremor is very common, affects up to 75% of people through the disease course. And fortunately, it's often pretty responsive to treatment. So the next cardinal motor symptom is rigidity or stiffness. And this is different from spasticity, but it's increased resistance throughout the range of the movement. And you can feel this by moving the patient's arm around passively or their legs. And you've probably all heard the term cogwheel rigidity. You don't have to have cogwheeling if you have Parkinson's, but that's actually usually feeling the tremor come out as you're moving the arm or leg around. But the cogwheeling is often just used to describe the feeling. Now the rigidity can occur in the proximal or distal muscles, and it usually is asymmetric and often on the same side that the tremor is affecting, but not always. Sometimes it can be tricky and be on opposite sides. There's a movement called the Froment's maneuver, where you can, if you don't see someone with a decreased arm swing and a little bit of tremor but don't find much rigidity, if you have them activate the opposite limb and then try to test the tone, you can see the tone will increase and come out, and that's seen in Parkinson's as well. And this rigidity can be painful because it can lead to other symptoms like dystonia and cause stiffness and discomfort. Actually, we see several patients who come in to be diagnosed with Parkinson's, and they've had rotator cuff surgery because they had trouble with rigidity in the shoulder that was misinterpreted as a shoulder problem. So rigidity can lead to a lot of postural changes, and this can be quite pronounced and disabling. So you can get axial rigidity or rigidity in the core, and that leads to abnormal postures like scoliosis and anterocollis, where the head comes forward. That's a flexion of the neck and the trunk, as well as we saw in that picture, the elbows are often flexed and held by the side. Then this is usually more of a late occurrence in Parkinson's, and if we see it early, we might think of an atypical Parkinsonism that's not idiopathic Parkinson's disease. But one very disabling form of this is called Camp-Cornea, where the posture is extremely flexed forward at the thoracolumbar spine, and the person can still lay flat, but when they're standing up, their spine is forward, and I'll show you a picture of that. And then there's another one called PISA syndrome, where the posture is leaning to one side or the other, and this occurs with sitting and standing. So this is some examples of Camp-Cornea, both in drawing and in pictures. So you can see that the patients can lay flat without any problem, so there's not a bony abnormality causing this, but they can't stand up straight. And so this often requires use of a walker, even if the balance isn't too bad, just to keep people from falling forward. And then PISA syndrome is the leaning to one side, both in the chair and while standing. And so that also can lead to a lot of risk for falls because people are leaning to one side or at risk for leaning over too far that way. And then that is, and related to postural instability and the risk for falling. So this is usually the latest symptom to show up, and there's definite loss of postural reflexes. So if someone, if one of us got off balance, we could probably catch ourselves, or if we tripped over something, but there's loss of that response to keep your balance. And it does lead to falling, and so it is one of the most disabling symptoms because it can lead to a lot of injuries, and it also leads to preventing people from going out to do other things because they're concerned about falling or don't want to be out in public with the walker or whatever. This is a really important time to get physical therapy involved, but we really try to get physical therapy involved with Parkinson's patients even early in the disease because it's one of the most important therapies that there is for these patients. Medications are great, but exercise and doing the right therapy to improve balance and keep walking safe is very important, and strengthening the correct muscles. So unfortunately, this is also one of the least responsive symptoms to medication. So sometimes people get better with their walking with medications, and it's just not always complete. And there are things like freezing of gait, where the the feet seem to get stuck to the floor and they can't move without really thinking about it. This is worse in narrow spaces like narrow hallways, or going into an elevator door or going through a doorway. People can get frozen. And if you see a Parkinson's patient frozen trying to get through a door, it actually makes it worse if you rush in and try to help them because that's even more crowded. So it leads to a lot of trouble when people are trying to be helpful, but really it can worsen the problem. There is a tendency to fall forward or backward because of the inability to correct the posture. And we mentioned earlier with that picture about the festination of gait, and that was in Mr. Parkinson's original description, where the steps get smaller and smaller and the body gets ahead of the feet, and you almost have to run. I've got several patients who have to stop themselves by heading toward a wall to try to stop their movement forward. So dystonia is another motor symptom. This is a descriptive term in movement disorders, which just means an abnormal twisting posture of the muscles. And this can happen frequently in Parkinson's disease. And it can be very uncomfortable, often occurs in the early morning hours, and can wake patients up from sleep. There's something called a Straddle Hand, and my picture is not showing up, I'm sorry. But you get ulnar deviation of the hand, of the fingers, excuse me, and then you have flexion at the metacarpophalangeal joints, and then extension of the more distal joints, and that can be very painful too. In the bottom right, the bottom left, there's a striatal toe. You get this profound extension of the toe, and that can lead, difficulty wearing shoes for sure. I've had several patients who have the toes cut out of their shoes or wear flip-flops all the time. And it can be related to the medications wearing off, or it can actually sometimes be worsened when you take medications, so it's sometimes hard to treat these. And then there's another example of the way the toes can be twisted to one side, and sometimes they extend or contract. A lot of different types of dystonia that can be painful for the patients. Now, motor complications also occur with Parkinson's. This is usually also a later aspect of disease. After patients have been on levodopa for several years, they can develop dyskinesias. So Parkinson's is a hypokinetic movement disorder, so there's loss of movement and slowness of movement. But dyskinesias are actually a hyperkinetic movement disorder, so there's increase in movement, and this is the wiggly movements. Like if you've seen Michael J. Fox in recent times, he's got a lot of dyskinesias. So they're sometimes disruptive to the patient. More often they're disruptive to the spouse, but they can actually lead to balance problems and falls. They are a long-term complication of being on levodopa. And then also you can get wearing off. So in the early days of taking levodopa, your brain, before a lot of neurodegeneration, your brain can still hold on to the dopamine fairly well, but as the dopamine neurons degenerate, you have less ability to hold on to the dopamine, and so the presence in the blood becomes very fluctuating. And so it might have a big rise where you feel like you're on and doing well, but then the medicine wears off, and so you feel stiff and slow and frozen before it's time to take your next dose of medicine. And that on time can also be associated with those dyskinesias, the excessive wiggly movements, so it can be very disruptive and hard to plan your day around. And then there's also something called dopamine dysregulation syndrome, where patients actually crave more and more medication and take more than they need because there's a feel-good phenomenon from taking dopamine. And so that's related to dopamine dysregulation and alterations in the reward system. So now we'll talk about non-motor symptoms, and I'm going to be a little bit brief here on this slide, but then we'll talk more about it when we get to the treatment section. So non-motor symptoms, as I mentioned early on, they've been becoming more and more recognized as important in Parkinson's. They are pretty common, affect 88% of patients have at least one non-motor symptom. They can sometimes come before the motor symptoms even start. And so as you remember from the Brock hypothesis, there are changes in the lower brainstem and in the olfactory bulb and in the GI tract that happen far before the motor symptoms occur. And so these non-motor symptoms can precede the motor symptoms. And while the motor symptoms are mostly driven by dopaminergic problems, the non-motor symptoms can involve other neurotransmitter systems like serotonin and norepinephrine, acetylcholine, and things like that. And they definitely have a negative impact on quality of life, and often more so than the motor symptoms. So these are a list of the non-motor symptoms that can be experienced by patients with Parkinson's. So mood disorders are fairly common. The depression of Parkinson's is not usually a suicidal type of problem, but just sort of a loss of sense of well-being that can come from that lack of dopamine. There's also a propensity to anxiety. Apathy is a big problem. It's like they stop caring about things sometimes, and this is very disturbing to the family. So if a patient no longer wants to play with their grandchildren, and it's just because they don't really care anymore, it's not an aspect of depression, but apathy itself can come from the disease, so it's hard for the family to understand that. There's cognitive dysfunction in Parkinson's. As I mentioned, this is thought to be a fairly late effect when the cortex gets involved, but if you study Parkinson's patients, even at the time of diagnosis, there is some degree of executive dysfunction, so problems with planning and doing things like that, and that affects a lot of patients as well. You can get psychosis over time, and the tip of the tongue phenomenon, where patients feel like they just can't get the word out or feel like their thoughts are slower, which is called bradyphrenia. Those things can be associated with Parkinson's as well. And then there's a lot of autonomic dysfunction. So we mentioned the GI tract involvement, but there's other involvement of autonomic systems. So you can get constipation, erectile dysfunction, urinary dysfunction, and other sexual dysfunction. There also are changes in the thermoregulatory system, so you feel like you're hot or cold frequently. And cardiovascular changes. There's changes in heart rate variability and breathing and things like that as well. There could be sensory symptoms with strange pains or changes in sensation, and of course the loss of sense of smell that we talked about. And then sleep dysfunction. I'm a sleep doctor also, so this is the one I'm most interested in and do research in. There's a lot of sleep fragmentation in Parkinson's. There's difficulty rolling over in bed due to the motor symptoms. So whereas you or I would get uncomfortable during the night and just roll over and never really wake up, if you have to have assistance to roll over, or if you have to have a bed rail to help you roll over or really work at it, then you're fully awake by the time you finally change position, and it can really disrupt sleep. There's a lot of daytime sleepiness in Parkinson's, and this can be due to the disease itself with the breakdown of neurons in the alerting systems of the brain, or it can actually be due to medications, and that's pretty common as well. And then there's parasomnias, and this is one of the prodromal features of Parkinson's is REM sleep behavior disorder, and I'll talk a little bit about that in a moment. You can also get a lot of leg kicks during the night that disrupt sleep in Parkinson's. So I mentioned that some of these symptoms come before the motor symptoms are present, and one of the most common ones is anosmia, so loss of sense of smell or hyposmia. And this is something we sometimes use to screen for patients for risk for Parkinson's in research studies. Constipation can also occur before the motor symptoms, as well as depression in some cases. And then, as I mentioned, the REM sleep behavior disorder. So this is a parasomnia during dream sleep. And normally during dream sleep, our bodies are paralyzed so that we can't act out our dreams. But because of changes in the brainstem neurons, this paralysis is sometimes lost in Parkinson's. And so patients can start acting out their dreams, kicking, fighting, punching, yelling out in sleep. And there's usually dream recall associated with that. And it usually happens in the early morning hours. You don't have to develop Parkinson's if you have REM sleep behavior disorder, but it is a high association. Something like 80 to 90% of people who have REM sleep behavior disorder will ultimately develop Parkinsonism. So it's a big association and interesting area for research because we can evaluate people who have REM sleep behavior disorder and possibly act before the motor symptoms of Parkinson's come out once we have neuroprotective or curative therapies to get these people treated before Parkinson's motor symptoms develop. So this is a normal picture of dream sleep from a sleep study. So in the top two lines are the eye leads, and then the next few are 4 EEG channels where we look at the different sleep stages. And then we have a chin EMG lead and an EKG and leg EMG leads, and then the breathing below that. So this is over 30 seconds, and this is a normal epoch of dream sleep, of REM sleep. And you can see the rapid eye movements on the top where the leads are rapidly dissociating from each other. And then if you look at the labels of EMG and the legs, there's not much movement there. They're not moving during dream sleep, which is normal. And then when we have the loss of that normal paralysis is when we can have dream enactment behavior. And this participant on the right had a epoch of REM without atonia, meaning that they are moving during dream sleep, which is abnormal. So moving on to treatments, so the important stuff, what do we do for our patients? And quick question, how many of you see or treat patients with Parkinson's? A lot of people, huh? Great. So hopefully this will be helpful along those lines, but medications that we use for Parkinson's is what we'll start with. So there are several different classes of medicines that we use. Levodopa is our most potent one and actually replaces the lost dopamine in the brain. Then there are dopamine agonists that bind to the dopamine receptor. There are catechol-methyltransferase inhibitors or COMT inhibitors, monoamine oxidase B inhibitors, anticholinergics, and amantadine. So I'll go through each of these. So levodopa, like I said, is the most clinically potent treatment that we have because it's replacing the dopamine in the brain. It is administered with carbidopa to prevent the levodopa from becoming dopamine in the periphery. We want that to wait until it gets into the brain before it converts to dopamine, because if it converts in the periphery, you get profound nausea and vomiting, and also then you don't have as much of it to be used in the brain where it's needed. So we have a lot of formulations of levodopa. There's the immediate release levodopa. There's a controlled release one, or actually two of those now, a controlled release and an extended release, and the brand names are listed there. There's an orally disintegrating levodopa that can be put under the tongue, and that's often used when someone is having severe off time and needs a quick on with the levodopa. There's now a surgical tube that can be placed in the duodenum jejunum, and it's carbidopa levodopa intestinal gel, and that's for a more consistent release, and I'll show a slide about that in a minute. And then there's actually just recently FDA approved and not quite available yet for prescription, but should be in the next month or two, a medicine that's actually an inhaled levodopa, so it's like a little inhaler. So that's a new formulation, and they're studying a pump for levodopa similar to an insulin pump. So a lot of different formulations becoming available. So levodopa can have side effects. The immediate or acute side effects can be nausea and vomiting, and again, this is because some of the levodopa may turn into dopamine in the periphery, and it's can cause severe nausea and vomiting if that happens. You can get orthostatic hypotension. You can get hallucinations and psychosis from the medicines, and this is usually more common in people who have later or more progressed disease. And then the long-term side effects, as I mentioned earlier, the levodopa-induced dyskinesias. So these can happen after you've been on levodopa at high doses for a while. And the dopamine agonists. So these are originally the ergot agonists, and we don't use these anymore. Bromocriptine, cabergoline, and lyseride, at least not in Parkinson's. They were found to lead to cardiac valve fibrosis, and also, they have different mechanisms of action there. Either 5-HT2B receptor agonists or the other serotonin. And then pramipexole is one that we do use frequently. It has immediate and sustained release formulations. Ropinirole is another dopamine agonist with immediate and extended release formulations. There's rotigotine, which is a patch, which can be really useful for some patients if they have swallowing trouble. Apomorphine is a short-acting dopamine agonist that can be used sort of as rescue if someone has an immediate off, and it's an injection, or there's now pump, and there are investigations into the inhaled and intranasal formulations. And I have a slide a little bit later talking about the mechanisms, how all of these work. But dopamine agonists have similar side effects to levodopa, but also some that are worse. So nausea, vomiting, and orthostatic hypotension can all occur with the dopamine agonists as well, and this decreases over time. People can sometimes get used to this and develop tolerance. Hallucinations, and this is especially true in older patients or cognitively impaired patients. And so if we have a first-time Parkinson's patient who comes in and is 75 or 80 years old, we usually don't start with dopamine agonists. Then another very common symptom with these agonists are daytime sleepiness. And actually the problems associated with sleep in Parkinson's were sort of revealed when people started taking these medications, because they were developing sleep attacks, these uncontrolled and unpredictable episodes of profound sleepiness that would cause falling asleep while driving and other problems. So I have to warn people to be very aware of these symptoms. It can also lead to swelling in the legs and to weight gain, although I don't see that quite as common, and can sometimes be useful in Parkinson's, which often leads to weight loss. And then something that's very important to tell your patients about, and this is true if you prescribe these medicines for restless leg syndrome too, but dopamine agonists can lead to impulse control disorders. And so this can be abnormal sexual activity, it can be gambling, internet shopping. I had one woman who told me that she was obsessively couponing. She went into Walmart, found a $1 coupon on Band-Aids inside the 99-cent Band-Aid package. And so she kept going in and out of Walmart to purchase more Band-Aids and had 10 or 20 boxes in her car and called our office. We've also had people gamble away life savings or start seeing prostitutes. All sorts of bad things can happen. So every time I prescribe these medicines, I warn the patient and their family members that this can be a problem, because usually the patient doesn't recognize it as a problem because it is a pleasurable thing to do. So they don't recognize that it's problematic. So COMT inhibitors are another class of medicine. These have to be used in conjunction with levodopa. They don't do anything if they're used alone. So entacapone is one that's combined with carbidopa levodopa, and the brand name for that is there. Tolcapone is another medicine that had been used but now has been associated with liver failure, so we don't really use that anymore. And the side effects related to this are just related to what the levodopa does, so it keeps it around longer. So that leads to any side effects that are present. And we often use this if someone's having wearing off because it lengthens the duration of the levodopa effect because it prevents it from breaking down. And so we use this a lot in wearing off. Mao-B inhibitors, these are frequently used early because they're fairly mild and have some symptomatic benefit without many side effects generally. So selegiline, rasagiline, zidoselegiline, which is one that dissolves, and sulfinamide, which is a fairly recently approved medicine to be used for off time with carbidopa levodopa. And then these medications are MAO-B selective, so they're less likely than the MAO-A inhibitors to cause the problems with hypertensive crisis and excessive tyramine. So we don't have to warn people so much about avoiding aged cheeses and red wines and things like that. But there is an increased risk potentially for serotonin syndrome if combined with antidepressants. There was one study that showed that this was not much of a problem, at least with rasagiline, but we still use a little bit of caution with that. And then we have anticholinergics to use in Parkinson's. So this is typically useful in younger patients who are not at risk for cognitive problems or not showing any cognitive problems, and in people who have predominantly tremor. Anticholinergics can be very, very effective for helping tremor, and sometimes it might be the only thing that's helpful, even when carbidopa levodopa is not, but it does have potential bad side effects, so we have to be very cautious. It's less helpful for Brady Kinesia also, so if that's a problem, it won't be very useful. And the side effects associated with that, so the cognitive impairment is potentially very severe. There can also be confusion, hallucinations, sedation, and feeling poorly. You can get dyskinesias with these as well. And then all of the anticholinergic side effects that we all know about are the dry mouth, blurred vision, constipation, nausea, urinary retention, impaired sweating, and tachycardia. So these can be very ugly medicines, but sometimes in certain situations can be useful. And then of course they can exacerbate glaucoma and prostatic hypertrophy. So use with caution. And then amantadine, interesting medicine originally for flu, and we don't really know exactly how it works. Acts on dopamine in some way, but it is actually very useful for Parkinson's, and it can improve akinesia, also improves rigidity and tremor, and it's one of the medicines that we can use to treat dyskinesias once they develop. So this can be a very useful treatment, and often can be used in people who have refractory gait problems. Sometimes the amantadine will help. But it can have side effects also. So amantadine, if someone comes in confused, if they're not on an anticholinergic, this is usually the first one we take off. Can lead to hallucinations. It can lead to insomnia. It's got some stimulating effects, so this can be useful for a sleepy patient, but we always have people dose it morning and noon, or if 3 times a day, no later than 2 or 4 o'clock. It can lead to nightmares, swelling of the legs. This is a picture of livedo reticularis, that latticing appearance on the skin. This isn't dangerous, but it can be cosmetically disturbing, and sometimes doesn't go away when you stop the medicine. So that's also something important to warn your patients about. It can lead to dry mouth and blurry vision, and also headaches, although I don't think I've seen that as a complaint from my patients. So this is a diagram of sort of how all of these medications work within the dopaminergic system. So in the center, you can see the 2 lines that are vertical that say BBB, that's the blood-brain barrier. So in the periphery, on the left part of the slide, you can see levodopa in red, and it normally is broken down by dopa decarboxylase. So the reason that we use carbidopa with levodopa is to prevent that breakdown in the periphery, and that leaves more available, again, to cross the blood-brain barrier to get into the brain where it's needed. And then there's also the COMT, which also breaks down the levodopa into dopamine. And so the COMT inhibitors, not into dopamine, but into 3-OMD. And the COMT inhibitors like entacapone and tolcapone, they can stop that breakdown. So again, allow more of it to get into the brain to be effective at the dopamine receptor. So then when we cross into the brain, on the right side of the slide, levodopa is normally converted into dopamine. And in the presynaptic terminal there, and then it's released into the postsynaptic, or into the synapse, and at that point it also can be broken down. So MAO is there as well, so rasagiline and selegiline and sulfonamide can block the MAO as inhibitors there to prevent the breakdown of dopamine, and so that's how those function. And then tolcapone can stop the breakdown through the COMT pathway. So that all leads to more availability of dopamine in the brain to act on that postsynaptic dopamine receptor that's on the far right, the D2R. And then the pramipexole, rotigotine, and ropinirole act directly on that postsynaptic receptor to cause the effects and make the dopamine receptor think it's got more dopamine. So I mentioned earlier the surgical therapies. So there's the carbidopa levodopa intestinal gel, and so it's actually a continuous infusion through a tube in the gut that goes for 16 hours continuously through the day. And the patients also have a button that they can push to give a boost if they need extra. And so this allows more stabilization of the dopamine in the system so that there aren't those fluctuations. So this is a very useful therapy for people who are having wearing off. It does reduce off time and increases the time on, and it provides more steady state levels. And then there's deep brain stimulation. Does anybody see anybody with a deep brain stimulator? Yeah. So this is very effective therapy. Of course, it is a brain surgery, so sometimes patients are a little bit reluctant, but it's very effective for treating tremor and is actually better than best medical therapy for some symptoms. So it does involve implanting an electrode in the brain, and it's attached to a impulse generator that goes over the clavicles or under the clavicle, similar to where a pacemaker would go. And it can be adjusted. It's got at least four different contacts on the stimulator electrode, and so those you can choose different ones to reduce side effects or increase efficacy. And you can also then adjust the amplitude of the stimulation and the frequency of the stimulation. And so a lot of different ways to change the settings so that you can get the best therapy for the patient. And it's very good at treating tremor and rigidity and slowness, and it does help improve dyskinesias. So this is a very important therapy that we use frequently. It doesn't seem to be quite as helpful for balance as for the other symptoms, and especially freezing of gait is not very responsive to deep brain stimulation. However, if you have gait problems that are responsive to levodopa, typically they will also be responsive to deep brain stimulation. So it can be really useful. These are some pictures of the targets that we use for deep brain stimulation. So the most frequently used one for Parkinson's is the subthalamic nucleus. And you can see that as the STN in the brain slice on the right. And that's also in the MRI on the left. That's where the STN, that person has bilateral STN stimulators placed. The electrodes are not as big as they look on the MRI. There's some magnetic artifact that makes it look bigger, but they're actually quite small. They're bigger than a thread, but definitely smaller than a pencil. And then the globus pallidus interna is another site. It's very useful for patients who also have dystonia. It's good for treating that, and that's on that right panel toward the left. And then the ventral intermediate nucleus of the thalamus is very effective for tremor, and we use that one most commonly for essential tremor. Not as often these days in Parkinson's because it's not as good at treating Brady Kinesia or rigidity, but very effective for tremor. So some medications that should definitely be avoided in Parkinson's, and that in general can lead to Parkinsonism. So most antipsychotics, like especially the typical antipsychotics and even most of the atypical ones, can lead to Parkinsonism and definitely are contraindicated in people who have Parkinson's. Metoclopramide or Reglan is definitely puts people at risk for developing Parkinsonism. So I have seen several patients with bad Parkinsonism that will get better if you take them off their Reglan, and they may have been on 4 times a day for 20 years or something, but it can definitely lead to Parkinsonism. So be cautious with your use of Reglan. We movement disorders doctors do not like it. Antiemetics like promethazine and prochlorperazine, those can all lead to Parkinsonism and can worsen Parkinsonism in patients with Parkinson's. And then there's some newer medicines that are used for chorea or for hyperkinetic movement disorders, like in Huntington's disease or in tardive dyskinesia, and those medicines can also lead to Parkinsonism. So if you happen to have a patient who has both Parkinsonism and tardive dyskinesia, you have to be cautious with these medicines. And then other things to use caution with in Parkinson's are those anticholinergics, mainly because of the cognitive effects. And then diphenhydramine, Benadryl. In anybody who's older than the age of 60 or 65, we use a lot of caution and can lead to cognitive problems. So now we'll talk about treating those non-motor symptoms. So for mood problems in Parkinson's, there's not anything that's specifically FDA approved for Parkinson's and depression and anxiety, but we do try to be thoughtful about what medications we choose. So for antidepressants, try to base the treatment on other symptoms that the patients have. So anxiety is commonly experienced in Parkinson's along with depression, so we might use a more anxiolytic type of antidepressant, like avoiding things like Lexapro and citalopram. And then if someone has insomnia, mirtazapine can help with people falling asleep, so that can be a useful one in concurrent insomnia and depression. And then bupropion is often a good one in Parkinson's because it doesn't exacerbate restless legs or leg kicks during the night or REM sleep behavior disorder. So, and it also has some dopamine activity, so it can sometimes be helpful in Parkinson's. And then for anxiolytics, benzodiazepines can be used, but just be cautious because it can worsen depression and also cognitive dysfunction. So treating cognitive problems in Parkinson's, so there's mild cognitive impairment, which is very common, even the early stages can lead to dementia. Certainly Parkinson's disease dementia is a frequently experienced problem as well, especially in later years. I mentioned earlier apathy and bradykrinesia. So the only FDA-approved medication for Parkinson's, dementia, and cognitive problems is Rivastigmine, and it actually can sometimes be useful for people who have REM sleep behavior disorder and hallucinations as well. And it has both transdermal and oral formulations, and it is a cholinesterase inhibitor. And not FDA approved specifically for Parkinson's, but donepezil and memantine can also be used. And then non-pharmacologic therapies like exercise, I think is very important. There's some data showing that exercise can help with cognition in Parkinson's and also in the general population. So treating psychosis in Parkinson's, this can be really challenging. Parkinson's patients can have a lot of illusions and delusions, and Capgras syndrome, has anyone heard of that? It's where you think that your spouse or loved one has been inhabited by someone else, so they look like the same person but are really a stranger. And so that can be very disruptive to the patient and their family members. Pimavanserin is the only FDA-approved medicine for PD psychosis. It's a serotonin inverse agonist and antagonist. And it can, as with all antipsychotics, lead to problems with potential for increased cardiovascular mortality. So anytime we prescribe these, we always discuss with the patient that there are risks for increased mortality with these medicines, but you have to weigh the risk and the benefit. If they can't function because of their terrible hallucinations, sometimes you have to take the risk. We always do an EKG ahead of time to see if the QT interval is prolonged. And then quetiapine and Clozapine are the only two antipsychotics that don't cause Parkinsonism. And so Clozapine, you have to do a lot of blood monitoring. It can lead to decreases in blood cells, aplastic anemia. So you have to monitor it like weekly with blood counts, so it's very hard to prescribe. But the quetiapine can be fairly easily given. And we usually start at like 12.5 milligrams. It's a teeny tiny dose compared to some of the uses in psychiatry, which are more like 300 milligrams. So it's very small doses are often effective. And then, of course, we avoid the typical antipsychotics because of risk for worsening Parkinsonism. All right, treating sleep dysfunction. So as I mentioned earlier, sleep fragmentation is really common. So this is a normal hypnogram or pattern of sleep that's experienced by an adult. And you can see that they have a fairly quick onset of sleep. And then the next lines are N1, 2, and 3 are the non-REM stages of sleep. And then REM is the green shaded bar. And so you usually have more of the non-REM 3-stage sleep in the early part of the night, and REM increases toward the end of the night. And you can see that happens normally about every 90 minutes. But these are two of my Parkinson's research patients, and you can see the profound difference, how often they're waking up and changing sleep stages. And there's much less of the non-REM stage 3 and much less REM sleep. So it's very disrupted and fragmented. So the ways that we treat that is, try to rule out things that might be contributing to sleep fragmentation, like leg kicks or sleep apnea or other nighttime problems. Trying to improve motor symptom control in the night. So sometimes we give a nighttime dose of levodopa to try to help them sleep and move better during the night so that they can not have that problem rolling over in bed. Sleep aids are not typically used because they can have unwanted side effects. But occasionally if someone has REM sleep behavior disorder, we are treating with things that help them fall asleep because that also combats the REM sleep behavior disorder. And then exercise, again, I'm going to talk about this a lot, but exercise is good for everything. But it helps with the cognition, helps with sleep, very important. Helps with motor symptoms too. So this might be helpful for everybody in the room. We could all use a little bit better sleep hygiene. So really important, maintain a consistent bedtime and wake-up time, whether it's weekend or weekday or work day or not work day. That helps your circadian clock know what's what and lets your brain know when it's time to go to sleep. You should avoid TV, reading, electronics in bed. You want to associate your bed only with a place where you sleep. So when your head hits that pillow, your brain knows, oh, this is what I do here. I sleep here and that's it, instead of this is where I hang out and watch TV. Also, the light from the TV, the light from your iPhone can lead to alerting signals in the brain. Don't watch the clock. So if you wake up during the night and notice that you've only been asleep for an hour, it's really frustrating and you become more and more anxious about not sleeping. Or if you're like, oh, I've only got an hour left to sleep, it's really frustrating. Or I'm waking up every hour on the hour. Whereas if you don't know, maybe you've slept for 8 hours and it was beautiful. So just don't watch the clock. And if you aren't able to sleep, then get up out of the bed and go somewhere else. Again, you don't want to associate your bed with anything stressful or with somewhere that you're not sleeping. So if you find that you're awake and have become frustrated and thinking, I can't sleep, then that's the best time actually to get up and leave the room and go somewhere that you are relaxed. Do something you find relaxing. Don't do daytime activities though. Don't pay bills, don't do work, don't clean the house, but do something calming and relaxing until you get drowsy and then go back to bed. So then there's that, avoid daytime activities. Minimize alcohol. So alcohol can help you fall asleep at night, but then as it wears off, it leads to sleep fragmentation and wakes you up more in the early morning hours. So it actually disrupts sleep overall, and it's less sound sleep as well. So minimizing alcohol can help with sleep and insomnia. And then if our Parkinson's patients have daytime sleepiness, we try to treat that by first seeing if there's a nighttime sleep problem that we can make better. Adjusting medications can be helpful. So I mentioned earlier that especially the dopamine agonists can lead to sleepiness. So they might need to be scheduled in a way that maybe can be combined with a strategic nap, or in a way that is less likely to impair them when they're about to drive a car. And then again, exercise. Exercise is helpful for vigilance as well. So strategic napping and strategic exercise. So if you're sleepy every single day after lunch, if you finish your lunch and go run or go walk somewhere or sit down and do sit to stands over and over and get some blood moving, you can sometimes combat that sleepiness. So exercise again. And then the REM sleep behavior disorder. So if you encounter anyone who has REM sleep behavior disorder, first of all, try to get them a sleep study, because sometimes untreated sleep apnea can look like REM sleep behavior disorder. Other things important are make sure that they're safe in their bedroom. So you don't want any weapons in the bedroom. There are stories of people firing a gun during sleep because they had it under their pillow and they acted out their dreams and thought they were shooting somebody who was after them. You can move tables and lamps away from the bedside so that if they do punch, they don't hit that table or lamp and break their hand. Padded bed rails are sometimes needed so people don't fall out of bed. I've got some patients who had to sleep on the floor with their mattress because, again, for falling out of bed. Sometimes the bed partner has to be in a separate room, or putting the patient in a sleeping bag. I had one patient who wore mittens to bed so he couldn't unzip his sleeping bag and escape and hurt himself. There are medications, but none of these are FDA approved for REM sleep behavior disorder. There is clozapine, which we usually use at very low dose, and it can completely suppress REM sleep behavior disorder, but doesn't actually restore the paralysis of dream sleep. It just stops the behaviors. Melatonin is usually my first line therapy. It actually does restore the atonia of dream sleep, and it's naturally occurring. It usually doesn't have very many side effects. It doesn't reduce the ability to wake up from sleep apnea, for instance, that clozapine can do. So I usually start at 3 milligrams 30 minutes before bedtime, and that can be very effective. Rivastigmine, as I mentioned earlier, FDA approved for cognitive problems in Parkinson's. There was actually a small randomized controlled study, crossover study, that looked at rivastigmine and how it did seem to reduce the frequency of acting out dreams compared to placebo. Levodopa could potentially reduce REM sleep behavior disorder just because it's a REM suppressant, so it makes you have less REM, so less REM sleep behavior disorder. There's one case study of 3 patients who got better with their RBD when taking donepezil, probably the same thing, suppression of REM. And then dopaminergic medications. Anecdotally, some of our patients tell us that they stopped acting out dreams when they started their Parkinson's therapy. So don't really know why that is, but that can happen. So in summary, Parkinson's disease is heterogeneous. I didn't talk about this a whole lot, but different patients have very different manifestations of disease. Some people have really tremor dominant disease. Some people have more balance trouble. And so it's, I often tell my patients, if you see somebody in a wheelchair who has Parkinson's, don't necessarily think that that's your path. Everybody's a little bit different. But remember that there are both motor and non-motor symptoms in Parkinson's. Symptomatic treatments for PD motor symptoms can be very effective, but unfortunately there's currently no cure or disease modifying or neuroprotective therapy. And then the non-motor symptoms can be just as disabling as the motor symptoms, so it's important when treating Parkinson's patients to keep those in mind. So happy to answer any questions. Yes, sir?
How long is the deep brain stimulation effective after you do the therapy, the shock therapy?
So it continues to be effective as long as the battery is continuing to work, and there are...
Patients don't get tolerant to it?
They don't become tolerant to it. The disease does continue to progress, so it doesn't slow down disease progression. So as the disease gets worse, we often have to adjust the settings, but it's not a tolerance, it's just that the Parkinson's is progressing. Yeah?
If you use Clozapine in one of these patients, do they have to be put in the registry just like the behavioral health patient would be?
I would assume so. I've actually not ever prescribed it because of the monitoring that's required, and usually it can get things under control other ways. But if that's the case for other things, then yes, probably so.